Hi, this is Dr. S.S. Honani. I am a surgical gastroenterologist and today I am going to discuss about appendicitis. We should know what is appendix. Appendix is a tubular structure which is connected to our large intestine. Where a small intestine joins the large intestine, there is a saccular structure of the large intestine called cecum. To the cecum, appendix has attached. Appendix is a luminal structure. It's a blind ending tube. It's like some pen cap with a empty space in it. So for any reason, if appendix lumen gets blocked, because appendix is connected to a colon, it is a dirty area, the secretions of appendix fails to drain into the colon and it results in blockage of the drainage, which results in infection and appendicitis happens. So causes of appendicitis can be differentiated into obstructive or inflammatory. For example, if some patients get flu, viral fever or some viral infection, for some food infection, if anything which will cause inflammation in the lymphatic system of the intestine, when the mucosal lymphoid follicles become enlarged, it may block the lumen of the appendix, cause appendicitis. So it is similarly, suppose when we get cold, we get neck nodules. No, same way, when any infection happens in the intestine, lymphoid follicles may become big. It is more common among children or at the earlier first 2 decades of life. And second cause is obstructive cause. For any reason, if the lumen get obstructed, maybe because of appendicolith, means concentrated fecal secretion forms like a stone and it may block the lumen of the appendix. Even worms can block the lumen of the appendix. Sometimes the food particles we eat, certain seeds or certain stone stuff, these can block the appendix. Whenever appendix get blocked, secretion if fails to drain into the cecum, forms an abscess, and when abscess happens, then patient will have pain. So how does patient present with appendicitis is, usually they present with a pain which is a little bit severe, associated with nausea. Initially they have pain around the umbilicus. After some time it will shift to the right side of the abdomen. Most of them will have nausea. Nausea means feeling of sensation of vomiting than vomiting, means a percentage of people having nausea is more than percent of people having vomiting. And certain times they have anorexia, not feeling like eating. Not everyone will have fever, but some amount of body temperature will be raised in case of appendicitis. But thing is that in case of pregnant women, if appendicitis happen, it's a different scenario, because most of the time these already in the first trimester, patients will be having already nausea called morning sickness, and their blood counts will be usually in pregnant women, when you do the blood test, WBC counts will be usually high normally, and because their abdomen is stretched, and many times they won't present classically like when a non-pregnant females present. So how do they present is, usually they'll have nausea, but it is confusing. They'll have high blood count, that is also confusing. Most of common presenting is continuous abdominal pain. When they have continuous abdominal pain, because sometimes uterus becomes big in a later trimester, it will shift the appendix too much upper and posteriorly, so that it's very difficult to locate the appendix clinically. But typical symptom is they'll have continuous pain, and if they have fever, that usually in body temperature will be more in case of pregnant females than the non-pregnant females. And since in a pregnancy the inflammatory reaction will be suppressed, that immunity kind of suppressed, so most of them may not present classical symptoms of appendicitis. But whenever we suspect appendicitis in females, we need to evaluate it thoroughly, and we should confirm that they have appendix or some other cause. So what are the other differential diagnosis of appendicitis is, even renal stones on the right side, renal colic, it can present as appendicitis. See, the differential diagnosis of in males is less. Sometimes ileocolitis or food infection can present in pain in the right ilia fossa, and in case of a renal colic, so in males the differential diagnosis is very less. In females, differential diagnosis becomes more, because then even any tubal pregnancy or ectopic pregnancy can be presenting as appendicitis. Even the torsion of the ovarian cyst can present as appendicitis. Sometimes something called Mittelmus disease, between the cycle at the time of egg release, some of the ovarian follicles rupture, it causes bleeding. That also present a sudden onset of pain in the right ilia fossa, and they will also clinically sometimes present as appendicitis. So now whenever you suspect appendicitis, how do you evaluate? Usually first line we do is we do a clinical examination. Once we do the clinical examination, we suspect appendicitis, we do blood test. Predominantly we see the total count. If total count is more than 10,000, 11,000, second thing is this, what is the percentage of neutrophils? If a percentage neutrophil increase, it says the infection is there. And CRP also raised in case of acute appendicitis. CRP should be more than 6. In pregnant females, all these are not significant because in pregnancy CRP is also raised, total count P also raised, they will have usually raised body temperature. So after the blood test is done, next thing we do is ultrasound scan. In ultrasound scan, we usually to present as a blind ending tube with surrounding inflammation, and we specifically we look for the diameter of the appendix. Normal diameter of appendix is 4 to 5 millimeters, and sometimes some people have 6 millimeter. So whenever appendix diameter is more than 7 millimeter or more than 8 millimeter, that means we suspect appendicitis. And sometimes in the ultrasound we pick up there is a lumen appendicolith, or we even sometimes we will be able to understand the complication, like whether tip any collection is there, any abscess is there, or whether ruptured. Next best investigation of choice. Suppose problem with the ultrasound is in a very fat obese people, it doesn't pick up properly, and it is a operator dependent, because if it is person to person, the diagnosis varies with the ultrasound, so it is very subjective. If the appendix, even ultrasound is normal, or appendix cannot be picked up in ultrasoundically, and if you are suspecting appendicitis, then we need to do is a CT scan. CT scan is very definitive. It shows where is the appendix, whether it is a retrocecal or it is a pelvic, or any appendicular mass has happened. Usually what I do is, whenever the patient present, especially after 45 years, if I suspect appendicitis, or in an old age patient presenting with appendicitis, I usually prefer CT scan. The reason is, in old age, one of the cause of appendicitis may be cecal malignancy. So if you do a CT scan, these are malignancies or anything can be picked up appropriately, and we don't miss out. So it at times happens is we do appendicitis just by ultrasound, and later a biopsy comes as a malignancy, then we have to do one more surgery, then it becomes very cumbersome. So my practice is, whenever in a old age, whenever has got a appendicitis, I prefer to get a CT scan. The reason is, if any malignant features are there, then it is also can be picked up. What to do in case of pregnant female when you suspect appendicitis? Usually we do a ultrasound. If ultrasound picks up okay, if ultrasound is negative, then we ask for a MRI. MRI will pick up, because why MRI not CT? Because CT, any radiation in the first trimester of a pregnancy can result in malformation in the baby or some congenital defect. It is more so if the dose of radiation is high. So it is better to avoid CT scan. Earlier they used to say that if you have a CT scan using less than 5 rads, it is okay and all. Now because that time MRI was less, now MRI is available everywhere, and we do a MRI abdomen, and we don't use contrast like gadolinium contrast. We don't use in pregnant women. We do just plain MRI without contrast. So 90 to 95% of the patient will pick up the cause. If appendicitis is there, we'll come to know. Then once the diagnosis is confirmed, next how do we manage? Usually depends on stage of the disease, how bad is the disease. If patient is having acute appendicitis and we think it is a inflammatory appendicitis, and appendix diameter is less than 7 millimeter or 6 millimeter, then we will offer sometimes conservative management, because usually what we do is conservative management. We will admit them, we keep them NPO, and we start IV fluids, and we give a proper antibiotic and tide over this crisis. Once this crisis is there, once their inflammations comes down, around 50 to 60% of the patient will recover with this treatment, and remaining 40% may progress, then we have to do a surgery. And suppose whenever the appendicitis is due to obstructive cause, maybe appendicolith or worm infestation is more than 8 millimeter, and there is a complication, sometimes ruptured appendix or tip abscess, gangrenous appendix, most of these things we can pick up through CT scan. When we suspect this, we usually straight away do offer the surgery. Now, what mode of surgery? For the appendix, now nobody should do open surgery. The reason is, open surgery doesn't offer any extra benefit over laparoscopic surgery. In fact, open surgery causes more problems because first of all, open surgery sometimes it's difficult to find the appendix, and second thing is incision is big. Maybe in thin patients, some people say that I do in 1 centimeter, 2 centimeter and all, but if you do 1 centimeter, 2 centimeter incision, the problem is not every time patient present with appendix will be having appendix. There are some other causes, differential diagnosis like as diverticulitis or torsion ovarian cyst, ectopic pregnancy, tubo-ovarian mass, a tubal infection. All these cases you won't be able to differentiate or you won't be able to do anything because you won't recognize that they are there when you do open surgery. And second thing with open surgery is there is always chance of hernia formation, wound infection and prolonged hospital stay. So open surgery should not be done for acute appendicitis. So the treatment of choice is minimal access surgery. You can do laparoscopy, we can do robotic also. Sometimes I feel robotic is overkill for the appendicitis, but still you can offer, suppose you are suspecting like appendicular mass formation are there and this patient is able to afford, we can still offer robotic. So what I do is usually I do most of the time laparoscopic. I use is bikini line incisions. What I do is I use a 5 mm camera at the umbilicus and 3 mm port and maybe one 10 mm port at the suprapubic region. All this comes below the under strap line, so and we can do a better job. The thing is that the minimal access surgery we try to do as minimal as aesthetic as possible, but whenever we are treating appendicitis, more than aesthetics, the treating properly is most important thing. Some people, sometimes patient will say, sir, you have to do only in 3 ports, I have minimum ports, you should not put bigger ports, I'll get scars, all those things. But no, it is not the choice in that way. We are not doing a cosmetic surgery, we are doing a life-saving surgery. In this case, what we do is, certain times we may have to put extra port, sometimes abdomen will be very much distended, our patients are very obese, then we have to put a bigger port. We say, we don't say that we are doing a cosmetic surgery, we are doing minimal access surgery. So the treatment of choice for appendicitis is minimal access surgery, because when we do minimal access surgery, if not appendix, if some other cause like diverticulitis or a tubo-ovarian mass, ectopic pregnancy, whatever the pathology, we can address at the same time. So after appendix, usually most of the time appendicitis is a daycare surgery. We diagnose, if we do surgery much earlier part, so maybe after 6 hours we start orally, maybe after 10 hours or 12 hours patient can go back home. And after surgery, what is the care? Okay, now after surgery, once infection is removed and there is no abscess formation, the appendix is not burst open, then what we do is we change all the medication into orally and we start orally immediately and send. Suppose a patient has got a lot of collection, abscess is there, mass has formed and we have to resect, means if bowel resection is involved, then we keep in the hospital for maybe 2 or 3 days till the bowel movement starts. If sometimes we may have to keep a drain in the after following surgery, then also we usually keep in the hospital only till the drain is removed. So after surgery, we won't say anything specifically, we tell them to have good hydration and predominantly veg diet and means high fiber diet and good hydration. And second thing is, I usually encourage not to take absolute bed rest. We ask them to mobilize as much as possible, active, but not to lift weight more than 7 to 8 kgs. For any further information about appendicitis, message us through WhatsApp. If you are having any doubt regarding your CT scan report, whether surgery is required or not, or any second opinion, you can contact us.